So Max, once again, thank you so much for your time. Now I think we can have a good meeting after this. So good. You see our slides, correct, Max?
Yes.
Perfect. So
can you hear me?
I can hear you.
Okay. Good morning. I'm João. I'm medical resident of the 5th year in urology here in Unicamp. Thank you for your participation. So in our clinical meeting, I'm going to present 2 cases. The first one, the patient FMS, 74 years old. He presented with gross hematuria 3 months ago. The patient came to our clinic complaining about gross hematuria 3 months ago without other complaints. He had high blood pressure. He's ex-smoker, 50 packs a year, and denies previous surgeries or drug allergy. He was in good general condition, lucid and oriented, the abdomen flat, painless, typical male genitalia, topical tests, and the distal examination of the rectum, the prostate of 4 grams, fibroelastic, and without nodules.
So just from here, I want to ask you, Max, is it common for you to see a patient 3 months after first hematuria episode, or this is less common? Like, how long is the hematuria patients that you see? Like, this is a common example for us, like 3 months of hematuria, then we see the patient. How it happens for you?
Yeah, so this is very common. So you know, there's a lot of data, and this data is not just in the United States, but is also international, that particularly women are delayed in their diagnosis. So 3 months would be more typical of a man. What we see with women is that oftentimes they'll go to a primary care doctor. It will be construed as a urinary tract infection. They may go to their gynecologist before they make it to a urologist. So women, oftentimes it's the data suggests that it's actually 6 months is more common before they make it to a urologist. With a man, they typically, with a man, they'll make it to a primary care doctor and then make it to a urologist pretty quickly, but they may be less inclined to seek attention for the first 6 to 8 weeks. And so 3 months would be typical.
Interesting. So from this point, you might have an image like a ultrasound and you go straight to the TUR, or how you usually manage such patients. Like, I can tell you, if we have a ultrasound that shows us a lesion, we go straight to TUR. How it happens? Is there any kind of exam you like to have, or you usually have before, or is like our practice here?
Yeah, if I have a CT or an ultrasound that shows a bladder mass, I will typically not go to a cystoscopy. I'll go directly to the operating room. However, there are some exceptions. If the patient is frail and elderly, or has cardiac disease or pulmonary disease, basically, if I'm not, I always tell a patient and their family, there's around a 10 to 15% chance that the ultrasound or the CT scan is incorrect, that it's a clot, it's a blood clot, or just debris that's layering in the bladder. And if I'm not willing to take that risk of a false positive because of their anesthesia risk, then I'll take them for a cystoscopy.
Right. Good. So we do about the same. And are you using any urinary marker like routinely, or?
I'm not using urinary markers for this type of case with gross hematuria. I will, I really don't use urinary markers to make the decision about whether to go to, for example, to the operating room or not.
So we use the regular light here, like not blue light or something like that. Do you have is it practice for you, like, to have at least a blue light or something to improve?
Yeah, so I use blue light routinely in my practice. For a patient with an obvious bladder mass, I don't feel that it's necessary. But for a patient with, for example, gross hematuria, where there's nothing obvious in the bladder, where you may have a positive urine cytology, I find blue light to be exceptionally helpful at identifying CIS of the bladder specifically.
The last point here is cytology will help you, will help us, like even if you have a tumor, etc., or just when you don't see anything and you need more information, so then you get a cytology. And we have lots of limitations for cytology regarding sensitivity. So how cytology is used for you routinely?
I use cytology as a tool to help me make decisions, but it is not going to be the deciding factor. So I rarely will use cytology alone to do a major operation, for example, because a cytology is only as good as it's very subjective. You need a cytopathologist that is reading many slides each week, and even then the sensitivity is not so great. Specificity is pretty good, but sensitivity not so good.
So we will go over with the case. We will advance with the case, and in the meantime, like regarding the grade classification, we moved from grades 1, 2, 3 to high and low. How you think that this does not represent or resemble the heterogeneity of bladder cancer, or how much have we gained, how much have we lost with this movement to make like binomial high low versus 3, that we can have something in the middle, and we have something, we have some data regarding our cases here, but would like to hear from you.
Yeah, so I think that anytime you have 3 choices, the difficult calls are going to be 2s. So when you go from 3 to 2, you force the pathologist really to make a decision. And I think that there's some things that are helpful around that. But what you're losing is sort of the nuances. And we all know bladder cancer is a combination of science, but is really a lot of art. There's a lot of art to how you manage bladder cancer, and so you're never gonna really recapitulate, or you're never going to define the true biology of the disease just by one thing. So grade is just one thing. Depth of invasion is one other thing. Eventually, we're going to have genomics. That's another thing. But you have to use all these things, and then patient factors. So I think it's more complex than simply grade 1, 2, 3 or high grade, low grade.
You know that there are some tools that tells the patient risk that still use grade 3 phenotype. So I have to tell you that we still value the grade 3 phenotype. There are a bunch of data showing that the grade 3 phenotype, the aspect of cells that look like grade 3, can tell a lot. So we still use or we still rely on that somehow. And how you value that? Did the pathologist give you something like that, this information, so you can rely on that, or you are not able to, or you don't think it's a good way of doing?
I don't think it's wrong. The thing I most focus on, most of these lower grade tumors are non-invasive. So I'm more focused on invasiveness and depth of invasion, and features like that. grade, really what I care about is it invasive or non-invasive. So
good. Let's go ahead with the case and very good conversation, Max. So very important aspects that we are remembering, all of us, how to look at those patients, and also discussing new or frontiers in the topic. So
we order a cystoscopy, a kidney and bladder ultrasound, and blood test. So the kidney and bladder ultrasound, it shows like a two pedunculated nodular lesion on left posterior wall, heterogeneous, with a flow on Doppler study measuring 1 centimeter, which in this context is suspicious for neoplastic involvement. The upper urinary tract was unchanged.
So just a second. So for the audience, the CT scan is mandatory. So even if you have a nice image here and you can really help the patient with the ultrasound, that usually we use as a screening tool, CT scan is mandatory for the upper tract and to improve the case. Would you use, Max, MRI and the MRI to give the kind of appearance of the bladder? What do you have to say about that?
I like MRIs. I don't use MRIs in this situation because MRIs are quite expensive and difficult to schedule here in my area. CT scans are much easier for me to get done. I use MRIs routinely for muscle invasive bladder cancer, where I want to characterize the depth of invasion and invasion of, for example, the vagina or the uterus or the prostate. That's where I find MRIs to be extremely helpful. I think they're helpful here for initial diagnosis and workup, but I just don't have the resources to get it on everyone in my practice.
So maybe we will have the opportunity, as we have with prostate, that we move from not helping at all, and now a lot of help with the MRI. With the field advancement, we might have the opportunity to stage them, or even in terms of local invasion. So I agree, and yes, it's part of the evolution of the technique also, because we need to improve how we do that. This is a really recent thing to use this for local staging, and really is the same what we do here. So go ahead, please.
The blood tests were unchanged in the PSA 1.5. We performed a cystoscopy to show the presence of two vegetated lesions, one measuring 0.8 centimeters on the right side wall and one measuring 1.5 centimeters on the left side wall with a tumor appearance. Just a question.
Go ahead.
In a case like this, in this situation, you see the lesion and it's like a tumor appearance. Do you often perform a biopsy in this case, or you just go to TURB?
No, the biopsy is a resection already. You don't need to lose your time there.
Okay.
Go ahead, please. Okay, go ahead.
So we opted to perform a TURB in this patient. The procedure without complications, we resected two lesions. Muscle layer sample was resected and sent separately for anatomopathological evaluation. And we opted to maintain the patient with indwelling urinary catheter for irrigation with saline. At the first post-operative, the patient was well, no complaints, the urine was clear. So we opted to remove the catheter and discharge the patient with return in 15 days. 15 days after the surgery, the patient was well and denies gross hematuria.
Right.
Dr. Atanasi.
So we have Professor Atanasi.
Yes.
May we have? Yes, thank you.
Okay. This is a urothelial carcinoma, and we can see that has also a focal squamous differentiation. Next image, please. And we have the invasion of the lamina propria, as you can see in this image. So the final diagnosis on this case is urothelial carcinoma of the bladder, papillary and non-papillary, with focal squamous differentiation, high grade. And we use also combined grades. It's 2+3 using combined grades. What does it mean? That most of the extension of the fragments of the sections is grade 2, but there is also areas with grade 3. The stage is PT1. And there was presence of only one fragment of muscularis propria showing no neoplasia.
Excellent. So, Max, here, I think we should do a re-TUR anyway. Okay, you agree, correct?
I agree.
And yeah, other point is this is just focal squamous. It's not a variant histology, so not that bad, correct?
Right.
Perfect. So going back, if you see a lesion that is lateral side of the bladder, like that one, go back to the image, please. Are you using anything to protect against like obturatory nerve reflex? I'm asking because it's not that common, but like 2 weeks ago, I had really bad obturatory nerve reflex for a volume of a very big tumor, and really that made a roll in the bladder because of the reflex. So it never happened to me before, but it was just 2 weeks ago. And what do you do? We know that we have many ways, like decreasing the energy intensity, very tight.
Can you see my screen?
Yes.
Okay. Yeah. So I want to show you a technique that I use for a lateral sidewall tumor. So there's two techniques I'll show you. This tumor was on the lateral sidewall. It's particularly difficult when it's CIS on the lateral sidewall. So what I would do to limit the obturator reflex, which is, I think, your question, is I would do this technique, which is called staccato. So you're tapping the energy and you're just pulling it. So you're tapping the energy, you're not doing continuous energy. And this staccato technique allows for resection of large amounts of lateral tumors that limit the obturator reflex. Now, there's another technique I'll show you that the tumor you showed me wasn't really amenable to, but was sort of, because it was papillary, and this also limits the amount of energy on the actual wall. And let me expand this. And that's an en bloc technique that I routinely also will use. So I'll show you one example of that. So in this technique, I'm just using energy to...
Doctor, when you expand, we can't see the video.
Oh, you can't? Okay, then I'll just do it.
Expand,
Sorry, I'll go back to staccato and not expand. Thank you for telling me. So once again, this is the staccato technique I was describing, where you're just pulsing the energy instead of continuous energy. And this, if you have a significant obturator reflex, then you're not going to damage the bladder if you're just tapping the energy, as opposed to continuous, which I just showed you, which is more dangerous. Now, the other option for a tumor like that would be something like an en bloc, more of an en bloc technique, where you're trying to limit the amount of energy on the bladder wall itself. And so you're literally just tapping the tumor and going and undermining it from below and getting under the tumor itself until it's off. And like this strategy. And that limits your exposure to the bladder and potential nerve issues. And then that is one way to, those are two different ways. So I just wanted to show you that. I'll stop sharing. Those are two different ways to sort of manage a lateral sidewall tumor where you're concerned about nerve issues.
So our case was like 8 centimeter case, and I really had to resect a lot. Was all the bladder was all full of tumors, like those like chronic tumors that the patient is as elderly and didn't take care of the bladder. So at the end was all TA tumor, very voluminous tumor, but TA. So but a very big tumor. But yes, those are helpful, and sometimes we might rely on anesthesia helps and something like that, like nerve blocks or etc. Good. So please, do we have no? Let's go ahead. Like
So just as you told, Dr. Lowe, we use a classification at NMIBC. So to classify the probability of progression after third.
We have our screen for the audience. Do we have the screen? You see our screen now next? Yes?
I don't, I see it, but it's not expanded, but I see it.
Yes. So in the meantime, Professor Birajara will make a question or comment. Yes, Professor, please.
Hi, Professor. I would like to know what is your experience with in-block resection. What size you do that?
Leo, do you mind repeating the question? I had trouble hearing it.
In block resection, what is the limit of the lesion size?
For me, the limit is somewhere around 3 to 4 centimeters. I do not like doing an end block resection and then having a tumor that cannot come out, where I'm then it just spray cancer cells all over the bladder anyway. So I find it to be most useful when it's a small or medium-sized tumor. A large tumor, I think is it possible? Yes. Is it helping the pathologist or the patient? I don't think so. So for me, it's right around 3 to 4 centimeters would be the limit.
So if it's possible, you always.
If it's possible, I would say I do most of the time. Yeah, okay. I don't do laser. I do mostly bipolar and block.
Excellent. So we should go ahead and with the case.
So here just to an example of the classification with like this patient is high risk patient, and what we use to do this classification is the age. Like our patient, it was plus than 70 years, so it was a primary tumor, multiple lesions, less than 3 centimeters, T1, no Cs. And here, as Dr. Lau told, the classification, the grade system, we use like both. So it's a G3 and high grade. So our patient is a high risk one. So in this case, it's a T1 tumor. As the EU guidelines said, we performed a new TURB. So the new TURB was performed without new lesions, the procedure without complication. We resected the primary tumor site and maintained it in the wheeling urinary catheter. The patient was discharged in our first post-operative.
Oh, go ahead.
And returned in 15 days without.
Now,
the patient came with chronic.
Show me the images first.
Yes.
Have the diagnosis.
Yes, please.
Now, in this transurethral resection, we don't see any tumor lesion. We see inflammation, chronic and specific cystitis, and also granulomas. Show the next image. Macrophages, most of them multinucleated. These are granulomas post transurethral resection. The final diagnosis in this case is chronic and specific cystitis post TUR granulomas and several fragments of muscularis propria without neoplastic tissue.
So good. This patient would get BCG. For you is the same. The short age is not that bad. So we have had a BCG in the last months or so. So you already have BCG right now, correct?
Yeah. What strain in Brazil? Do you guys have multiple strains in Brazil or just one?
No, just one Rio de Janeiro strain that is came from Moro strain. Or no, Moro strain.
Okay.
That's the one we have. Okay, so we can have your talk or just show a quick case. How long you want to use for your talk, Max?
My talk is around 10 minutes. I do need to go to the operating room in around 20 minutes. So
Okay, so we can see one quick case and go to your presentation. Good.
Can we just talk this?
Yes, yes.
Like, about this case, doctor, we performed like a cystoscopy and BCG like for 24 months. So the patient presented no new lesions and the histology was always negative. Do you continue like this patient to do BCG for 36 months? Maybe 12 months would be enough?
the textbook answer is yes. I do it for 36 months. However, very few patients make it to 3 years. That they usually toxicity increases the more BCG you give. Typically, toxicity will start after 9 installations and definitely by 12. Frequency, urgency, burning. And so by 18, by a year and a half, by 18 installations or 2 years, usually patients are done. And I'm okay with that. So very few patients are symptom-free and able to go to the full 3 years.
Okay, so but at least 2 years, or maybe some patients will just finish with 1 year or so. There are also some patients that don't go to 2 years. Is that correct?
That's correct.
Yeah. So is there just show the article out, please. This is what we made of our grade 3 phenotype. So when we look at the data regarding the grade 3, once we have a very careful and a pathologist, an expert pathologist as Professor Athanasi Dilis, so we have the opportunity to look further to the pathology grade, and we usually have something called Unicamp grade that is like Gleason grade. We do this is made by Professor Athanasi like 20 years ago, first published. He just proposed that we should do, to represent the heterogeneity of bladder cancer, we should use 2 numbers as we do with prostate cancer. So that's what we do. So we offer 2 numbers. The first number is the most extensive part, and the second number, similar to Gleason score. You understood that, correct, Max? Yes. So
Yeah.
go ahead, show what we got for that. What slides?
As we know, the current grading of bladder urothelial carcinoma relies on the highest pathologic grade of the specimen and does not reflect the inherent qualitative and quantitative heterogeneity of disease. This is a retrospective study with urothelial high-grade T1 submitted to adjuvant BCG between 2008 and 2015 to evaluate the prognostic potential of grade 3 according to the 1973 World. Okay, go ahead.
What we see.
As we can see in this Kaplan-Meier graphic, grade 3 presence independently predicted time to progression, and grade 3 predominance independently predicted time to disease-specific death. The current pathological classification of bladder cancer fails in the characterization and quantification of high-grade phenotypes, mainly T1 high-grade. This study proposed 3 practical and accurate prognostic grade groups defined by grade 3, absence, presence, or predominance.
Yes, I can tell you. So then based on this data, we can discuss if we can do like, if you have a grade 3 predominance for high grade T1, you can be better invasive or better supported for like cystectomy, while if you have like just focal grade 3, you might go for something that is not cystectomy. This is just something else and needs confirmation because it's a retrospective study. But you see that we made this figure to help us understand, and we see the pathology phenotype, and it's very clear that you have like here in the image, the clutch between grade 2 and 3, and here just pure grade 3. The phenotype is really different and related to outcomes, clinical outcomes. Any comment on that, Max? Really limited data, but really intriguing or potential data.
No, I mean, I think it is very interesting, and you're very fortunate to have a team like you and Professor Athanasi there with you that's able to look at this in such detail. I think that, it's an interesting concept to try to do this. The question is, this is a very experienced pathologist that's doing this. How reproducible is it to do this with, for example, a general pathologist out in the community? That would be one of my questions.
Professor Athanasi,
yeah.
will tell you, Professor
Yes,
Athanasi.
I agree. I fully agree. The problem, I think, is the reproducibility of this.
Excellent. Yeah. So Max, thank you so much. I think we can move to your talk.
Okay. Let me share my
Professor,
slides.
Last one question. In your practice, do you perform like a small tumor T1, but it's recurrent? Like if it's high grade or 3+3 and recurrent, do you perform cystectomy? Or how do you manage this
Is your
patient?
question after BCG?
Yeah.
So if it is a high-grade T1 tumor after BCG, I am going to think very carefully about a cystectomy. And yes, I will. Often will perform a cystectomy. Some patients don't want a cystectomy in that situation, but I find that when you do a cystectomy for recurrent T1, it will often be upstaged at the time of cystectomy. So it will often be muscle invasive. It will often have positive lymph nodes. So T1 after BCG is a poor prognostic sign.
It's very important, Max, to say that these you were talking about refractory or something like that. Not if the patient owns in his or her life had BCG and then recurred. Like this
Right.
is really, okay. So during BCG or in the first 6 months,
I would say within the first 6 to 9 months, if they have T1 come back.
That's very important because people sometimes ask the patient, "Have you ever had BCG?" So yes, 5 years ago I had. So go straight to cystectomy.
Right.
That's not correct. This patient, you still give BCG, correct?
Yes, that's correct.
That's important. So we're glad to see your to hear you, and if you want to share a screen or just yes, please, Max. Yes, we can see your screen right now.
All right. Can you see it okay? I'm having to the presentation mode is, I don't think it's working, so I'm going to do it like this. Is that okay?
Is that okay?
Can you try again now? I stopped sharing my.
You want me to try the presentation mode?
Yeah, the full.
Okay. What about now?
No, it's good enough, Max.
Can you see? Can you see it? No.
Yes, we see. It's good enough. It's very well. It's good.
You see it right now?
I see. So
okay.
Our room see the audience sees.
Okay. All right. So today I'm going to be talking about BCG alternatives and how we should think about BCG alternatives. This is a talk I gave at the AUA, and the context of this is the United States continues to have major issues with BCG shortages over the last 10 years because Merck is now the only supplier. And this is true not just in the United States, but in every country. Usually there's only one BCG supplier. It's difficult to manufacture. And all of these manufacturing commonly have issues. So it's very frequent to have plants get shut down and have shortages. And the question is, well, what do we do during shortages? And can we have alternatives to BCG? So there's a randomized trial that has finished accrual by my colleague, Rob Svatek, who actually the last time we went to Brazil, Leo, I forget if that was in Sao Paulo or I forget where that was, but when Professor Svatek came, we came together. He's finished this trial where they've randomized patients to Tice BCG or a different strain, a Tokyo Japanese strain. And so hopefully we'll have more BCG, but for now we don't. And there are many, many different options now that are coming, okay? Only one right now has been FDA approved in the United States. That's pembrolizumab. And that is an immune checkpoint inhibitor, a systemic immune checkpoint inhibitor for patients who have recurrences with CIS after BCG. But there are many more drugs coming, and I'll go over some of these.
So just quickly,
yeah.
Next, your slides are not moving forward, so would like to.
Oh, they are? Okay, so
No,
maybe
no.
I'm going to try doing it like this, Leo, because
Good. That's good.
I think it'll be easier. So anyway, so this is, I was saying there's a shortage. There's a randomized trial by Professor Svatek coming, and there's many options for drugs. And I'll go over some of these, but the only one that's FDA approved is this one right here, which is the pembrolizumab, which is a checkpoint inhibitor for patients with recurrent CIS after BCG. But, you know, there's issues with that, and I'll go over that. So what is the current paradigm? Well, the current paradigm is you get BCG, and then if you recur, you get a second-line therapy, or you go on a clinical trial. And then if you recur, you get a radical cystectomy. But where are we trying to go in the future? Well, in the future, you'll get BCG or maybe, hopefully, an alternative to BCG. You'll get a second-line therapy. You may get a third-line therapy. You may get a fourth-line therapy. And so radical cystectomy for non-muscle invasive bladder cancer is not used. That's where we're trying to go, or is used less often. But how do we get to that future? Well, we need drugs that are not very toxic, that patients are not progressing to muscle invasive cancer, and where recurrences are low. And then to the far future, where are we going in 15 years, 10, 15 years? Well, we'll have a biomarker, and the biomarker will tell us whether a patient is more likely to respond to therapy A, therapy B, and therapy C. And so we'll never need to go on to second or third line therapies. So this is where non-muscle invasive bladder cancer management is really going. So why is pembrolizumab FDA approved, but not really used by urologists in the United States? Well, the reason is that the 12-month complete response rate among patients with CIS is not just 19%. That means 81% of patients will recur within a year. And the grade 3 to 5 adverse events is 13%, which is very, very high. So most people are not going to prescribe a drug where the 1 year response rate equals the toxicity. And so I've developed this equation that suggests that urologists will use a second line therapy if the 12-month complete response rate over the grade 3 to 5 adverse events is greater than 3. And this assumes a low progression rate. You don't want a high progression rate, so it would need to be less than 5%. Now, how did I get to this ratio of 3? Well, let's talk about cystectomy. So cystectomy, we know, is curative here, but it's also toxic. And it's in the guidelines that these patients should be offered a cystectomy, the AUA guidelines. So let's just imagine that adverse events are roughly similar to Calavian surgical complications, okay? So for radical cystectomy, 12-month CR is close to 100%. 12-month complete response, close to 100%. Let's say it's 95%. Flavian complications, grade 3 to 5, is around 25%. So this gives us a ratio of 3.8. And that's our benchmark of how surgery will perform. So now let's look at pembrolizumab, which is FDA approved. Well, its 12-month CR is 19%, and its grade 3 to 5 adverse events are 13%. That's a ratio of 1.46. That's not going to work. Surgery is much, much more attractive in that situation. What will it take for a successful combination therapy with pembrolizumab? So there are many clinical trials right now trying to combine intravesical therapy, for example, with pembrolizumab. But how should we think about how this will be successful? Well, if we want to have a ratio of efficacy to toxicity that's greater than 3, then if we have a completely non-toxic drug that is combined with pembrolizumab, suggested here, then its efficacy will need to increase by 20 points in order to get to ratio of 3. If we have a combination drug that's a little toxic, that is has a 5% grade 3 to 5 AE, then it will need to increase the efficacy of pembrolizumab by 35% in order to get to a ratio of 3. So this is how I think we should be thinking about combination therapy, is by efficacy over toxicity. And when we look at all of the drugs that are coming down the line for non-muscle invasive bladder cancer, they actually all perform pretty well, actually much better than pembrolizumab. I think it shows that we really can get to a point where we get to lined therapy, first line, second line, third line. But this is how we should be thinking about it. And so I'm particularly interested in this combination of chemotherapy with gemcitabine and docetaxel. First, it's available all over the world. Second, it's cheap. Third, there's data that suggests that it works very, very well. And so because of that, and you can see the efficacy over the toxicity is very favorable from what we know. So we surveyed urologic oncologists in Canada and in the United States and found that more than 3/4 or around 3/4 are currently prescribing gemdosi for bladder cancer. And most are prescribing it for BCG unresponsive disease, 66%, but 1/4 have been prescribing it as first-line therapy when there likely is no BCG available. So they're already prescribing gemdosi at frontline. So based on this, we opened up a phase 2 trial evaluating gemdosi for BCG naive non-muscle invasive bladder cancer, and it's fully accrued. And this is just single arm. And what we've found is that none of our patients, of the 23 patients on the trial so far, none have recurred with cancer on that we've given gemdosi to. And actually now around 6 or 7 have already been followed by it for a year. So this is ongoing, but pretty exciting. And so we're opening later this year a randomized trial called the Bridge Study, 870 patients randomized to BCG versus gemdosi, non-inferiority design with a primary endpoint of event-free survival that's defined as time from randomization to a high-grade recurrence in the bladder, progression of disease or death. So we are very excited about this trial because we really think it hopefully will present the world with an alternative to BCG, which we all desperately need. So just in conclusion, I think there's options coming down for BCG alternatives. And one way to think about this is 12-month CR over grade 3 to 5 adverse events. And gemdosi may be one option that we're currently assessing. That's it.
Thank you. So is this investigator-initiated trials or?
So yeah, so the first trial that I showed, the single-arm study, was investigator-initiated and funded within our institution, just at Hopkins. But the second trial is through the NIH, National Institute of Health, and the National Cancer Institute is funding it, and it'll be at 200 sites, large trial.
The question is because you see that there is not much interest in funding something that is cheap and like BCG or even your good ideas there. So we have had such problems like how to fund such studies, and we usually go to the same sources like government or something.
Yeah, the only way we were going to get this funded, the randomized trial, was through the government. There's no industry to fund it.
Oh, very good. I wonder if we can recruit patients in your study here. We are improving our how we select patients for trials. So even for bladder cancer, that is a challenge. So I wonder if soon we can help you recruiting here and around. Brazil is an interesting place because we have a BCG at birth. So we might have some differences, but it's good to learn more regarding this kind of population. Do you think the fact that we are in a place that is tuberculosis endemic, and we get BCG vaccine at birth, so do you think the disease might be different, and even the BCG response can be different? I think so.
Yeah, I think so. I think it's an interesting thing to think about, and would love to collaborate more with you and your team on that.
Excellent. So the other thing is, before anything, let's go to questions. I think any questions or comments? No. So I think if you didn't do, I think and I would love to help you with that. I think you should spread your equation by publishing it. I know that you might have some critics. But that's good. It has a meaning. So if no one says anything, no critics, something is not good. But if you have critics, that has a meaning. So do you have a plan for that, or you just want to use when you publish your data, or you think it might be worth an editorial or a short something? Because I think it's really strong rationale, even simple but strong for thinking how to improve, how to use data, how to
Yeah. Thanks for saying that. I've been surprised by the amount of attention and publicity that equations got at the AUA. So I wasn't expecting that. So I may publish it now. You should.
Yes. Before we finish, again, we as we talked at AUA, we are glad to have visiting a staff from your side, like residents or even staff. And we discussed that we might be able to have visiting residents on your side, like for the system, the Hopkins system, under your surveillance or something like that. Just short visiting, because our residents might have like 4 weeks or less, just to visit as part of their international interaction. And we would be glad if that happened like systematically as a interaction that we want to keep for both sides. Is that after we talk there, like do you think that can happen? Like,
yeah, I do. And you know, one thing that I always think about whenever I come and visit you and not, you know, whether be it you know where you are in Campinas or in Santos, is I always feel like I learn so much. So I would also like to be able to send some of my trainees down there and have that collaboration. So yes, I think that would be wonderful.
excellent. We are glad that happens, that we can be also helpful with the interaction. So it's both sides good. So Max, thank you so much. I really appreciate. Thank you for your time. Wonderful talk and wonderful conversation regarding the cases. We have learned a lot, and it's always good to have you interacting with us. Please feel free to, or please be in the radar our interactions. We will remember to invite you soon again. And thank you so much.
Thank you. Bye-bye.
Bye-bye.
Thank you, Professor. Você vai falar?
Então, com isso, então a gente termina a nossa reunião semanal e nós voltamos então na próxima quarta-feira. Muito obrigado a todos, tenham um bom dia.